So, good evening, Dr. Neha. Are you able to hear?
Yes, I'm able to.
Okay. So, today we'll be talking about secondary prevention of stroke and how to optimize the low density lipoprotein cholesterol. And there is a debate actually on this, whether it should be reduced or not. And see, so the causal link between elevated low density lipid cholesterol is the cornerstone of modern vascular medicine. And there are a couple of things which were very important to understand here. Mm, Lower is better. The sooner, the longer, the lower. That's the slogan that is now given to this mode of treatment, intervention, what you can say. So we'll talk about LDL cholesterol and PCSK9 pathway and some of the clinical trials which have helped us come to this conclusion. So the primary driver of atherosclerosis, as you know, is LDL cholesterol. That is very, very important to understand that we keep talking about serum cholesterol level, but what exactly is that is the primary driver is LDL cholesterol. And the apolipoprotein B, which contains the LDL particles, keeps on circulating in the blood. And whenever uh, there is a velocity of blood is increased where the major arteries branch, then there will be some pressure generated and the transendothelial ingress takes place of these apolipoprotein B containing LDL particles, and they reach the subendothelial in the arterial intima region where they create some type of chronic inflammation due to oxidative modification, and there will be some macrophages which will take up these inflammatory things and foam cell formation. And there is a what do you call there is a cap, fibrous cap which comes, and that's very, very uh, significant because it may cause thinning and it becomes vulnerable, and necrotic core can invite the thrombosis. So that's how it goes. That's the most important thing to understand. So atherogenesis actually originates in the subendothelial intima, as you have seen, where this ApoB containing LDL particles infiltrate via transcytosis. They become trapped by proteoglycans, and the prolonged retention exposes them to oxidation by reactive oxygen species and lipoxygenases. Functioning as a dangerous associated protein, the resulting oxidized LDL triggers upregulation of VCAM1 and ICAM1, and these receptors they trap monocytes and T lymphocytes into the vessel wall. So there is one thing called a lipid ear concept. What if for the spelling mistake? It's a lipid ear concept. So cumulative LDL cholesterol accumulation from the younger days, and which creates a chronic inflammatory state in the vessels, and the plaque keeps on remodeling. So there is an equation and how this LDL cholesterol exposure gives over time to what type of toxicity. So analogous to pack years of smoking, cumulative LDL-C exposure captures both the intensity and the duration of the risk. So to understand better, moderate elevations over decades may equal short-term very high LDL cholesterol in total burden. So secondary prevention means soon after the stroke or any major cardiovascular event, if you measure LDL, and it should be kept at a lower level. The primary prevention we are not aware, and but the main talk is mainly about the secondary prevention. So if one goes into the literature, it says that that lifelong LDL exposure drives atherosclerosis. Higher cumulative levels increase the risk of coronary artery disease, myocardial infarction, ischemic stroke, peripheral arterial disease. All these four major things can happen. So this cumulative LDL exposure model, this is a ROC curve that is there. And so you can secondary, the sensitivity of the exposure model means as you increase the exposure, the concentration goes on increasing and the risk goes on increasing. That's what is the understanding of this curve. So the longer it is has got more higher levels, the risk is more. So first we dealt with the LDL cholesterol. Now it is a PCSK9 pathway. So this is uh, a very important aspect to understand in cholesterol metabolism. And PCSK9 is a chaperone protein that is circulating in the brain. What it does normally is that it gets attached to the receptors on the hepatocytes. And so what they do is these receptors undergo lysosomal degradation because of attachment of the PCSK9. So as a result, the LDL, which is supposed to attach to the receptors and get internalized into the hepatocytes and get metabolized, is not being done. So higher plasma LDL will result, and that leads to chronic inflammatory state in the subintimal region. But the lower plasma LDL happens when this thing is blocked. The PCSK9 chaperone protein, which is getting attached to the hepatocyte receptors, is blocked. These receptors don't get internalized and degraded, but they attach LDL cholesterol to themselves and they take it into the liver and metabolize. That's how the lower LDL levels result. So the PCSK9 pathway is another important aspect which one should understand. So normal pathway, the surface LDL receptors and PCSK9, you can see that co-internalization and lysosomal degradation. This is the normal pathway, inhibition pathway. So when we use a drug to cause inhibition of this, it escapes degradation and recycle. This receptor recycles to surface and catches LDL cholesterol and actively metabolizes. So reducing the level of serum cholesterol. Now, cerebral circulation and atherosclerosis. You know that curved arterial segments are where the atherosclerosis is manifest. There is a low wall shear stress. The wall shear stress is less than 4 dynes per second. And here the chronic inflammatory activity is going on. So at the carotid bifurcation level, if you look at it, there is a low oscillatory wall shear stress at 4 dynes per centimeter square at that bulb. And the architecture is plaque ulceration, superficial erosion, and intraplaque hemorrhage. And how do you do that? You do echogenicity on ultrasound, calcification on CTA, and intraplaque hemorrhage on MRI. That's how you diagnose this type of atheroma. And what are the mechanisms which we should see? Endothelial preservation, reduction in superficial erosion, and inflammatory cell density. So the therapeutic targets are these. But as in contrast to carotid bifurcation, if same atheroma in cerebral microvasculature, where there is high pressure, low resistance, so perfusion of parenchymal arterioles is possible. Lipohyalinosis changes, microatheromas, and fibrinoid necrosis results. So that leads to white matter hyperintensities on MRI and cerebral microbleeds. So here we have to restore the vasomotor metabolism by enhancement of eNOS synthesis, endothelial nitric oxide synthesis. That should be the target for cerebral microvasculature, and usually silastazole is supposed to help in this. That's why whenever you observe, whenever you have 5 white matter hyperintensities, you should think of silastazole as a secondary prevention treatment. So far we learned about LDL cholesterol and then PCSK9 pathway. And now there is enough evidence in the literature that we should reduce LDL cholesterol. But LDL cholesterol is a surrogate marker. What we are interested in knowing is, by reducing LDL cholesterol, are we going to prevent stroke recurrence? That's main clinical outcome which we are interested. So these secondary stroke prevention, cholesterol lowering therapies are usually, the pathways involved are usually atherosclerosis, the HMG-CoA pathway, a key enzyme that is involved in cholesterol synthesis. And prototype trial is the Sparkle trial, and which has studied high dose in atorvastatin within past 1 to 6 months of stroke. An initial level they recorded was 100 to 190. That's a very large trial, 407, 4,713 patients, 8 atorvastatin 80 milligrams, absolute risk reduction of 2.2% over 5 years. So that is one drug. Second drug is ezetimibe. Ezetimibe prevents absorption of cholesterol from small intestine. It interferes with cholesterol trafficking, decreases cholesterol LDL more than 70. So still 70 milligrams LDL is not an optimal level. We require to do something more. Okay. Other one is the PCSK9 inhibitors, that is a pro-protein convertase cetirizine kexin type 9 inhibitors. These monoclonal antibodies bind to PCSK9, a liver enzyme that inactivates LDL receptors, thereby allowing additional LDL receptors to be available to remove LDL from the bloodstream. PCSK9 inhibitors are administered subcutaneously and can dramatically lower LDL cholesterol levels. There are a couple of trials which I tabulate also, but briefly I'll mention here, and again we'll consider them in the tabular form. The further cardiovascular outcomes research with the PCSK9 inhibitors in subjects with elevated risk, that 4-year trial, you just look at the number, 27,564 patients, evolocumab, a PCSK9 inhibitor or a placebo, there is absolute risk reduction of 1.5% composite outcome and absolute risk reduction of 0.2% and secondary outcome of ischemic stroke. Another study, ODC outcomes, evaluation of cardiovascular outcomes after an acute coronary syndrome during treatment with eloricumab. Here also 18,924 patients, and this is also another PCSK9 inhibitor or placebo. So for our composite outcomes, ARR 1.6% for placebo and 0.4% reduction for the placebo and 1.6% reduction for the intervention group in second fatal or non-fatal ischemic strokes. So HMG-CoA reductase, statins inhibit intracellular cholesterol, and here another drug is introduced, that is bempedoic acid, and this all these upregulate the surface LDL receptors, and that leads to increased clearance of LDL cholesterol. So if you want to really know where it acts, small intestine, these Niemann-Pick like any receptors, that's where ezetimibe acts and prevents absorption of cholesterol. So let's review the studies. Sparkle trial, as you said, is the first trial proving statin efficacy for secondary prevention of stroke in patients with no coronary artery disease. So far, what has been adopted is a trials from cardiology. So indirectly there, but this is the first trial only addressed stroke in about 4,739 patients with recent stroke or TIA, and they do not have any coronary artery disease, and these are followed for almost 5 years with a high dose atorvastatin versus placebo. In these patients, the baseline LDL cholesterol is 133, but with treatment, it achieved to 73 milligrams in treatment group, and placebo 129. It remained almost the same. So, what fatal or non-fatal stroke reduction is 16%. And this hazard ratio 0.84, and the p-value is significant. Ischemic stroke reduction by 22%. As I said, this is the first trial proving statin efficacy for secondary prevention of stroke. But still, stricter control is required of LDL. So other studies have come. TST trial, where 2,860 patients with the recent ischemic stroke, TIA, and documented atherosclerosis. So the target LDL here is less than 70 versus 100 plus plus minus 10 milligrams per day using statins plus ezetimibe. So the baseline in this study was 135 milligrams per day of LDL cholesterol. And with treatment, they achieved 65 milligrams. That means half of it, they had 50% reduction. And in placebo, didn't reduce that much. That means by lifestyle modification and other things. The primary composite MACE reduced by 22%. Hazard ratio is 0.78 and the p-value is 0.03. So this is a French cohort which followed about 5 years. It showed 27% reduction in stroke and revascularization. So LDL reduction is leading to stroke reduction. It almost said 27%. It's the direct head-to-head proof that targeting a lower LDL cholesterol is superior to a moderate goal. So in addition to in nowadays, what we do is we start statins, but we should change our practice and go to add ezetimibe. So the another study, that is improved stroke sub-analysis. Here 18,144 post-acute coronary syndrome patients. They are followed for about 6 years median. And here simvastatin is added to ezetimibe versus simvastatin alone. Baseline LDL is 95 and it achieved 53 in treatment group and 69 in simvastatin group only. The ischemic stroke reduction is almost 21%, and it is statistically very significant. The subgroup with prior stroke had 8.6% absolute stroke reduction. That is, numbers need to treat is 12. So if you treat 12 people, then for a period of 6 years, one will be no one will have no stroke. Proved that non-statin mediated LDL cholesterol reduction provides additive neurovascular protection. So that's where the combination is coming into effect. And Evotopia 75, here also it's a Japanese study with 3,000 3,796 patients more than 75 years old. The elevated LDLs, no prior coronary artery disease. Ezetimibe 10 milligrams per day versus dietary counseling, that usual care. Here the LDL baseline is 162, and with treatment it achieved 120, but versus 131 in the dietary group. See, the MACE is reduced by 34%. Amazing. Stroke incidence was neutral, but see, that's where the confusion lies. Is it only coronary or is it also cerebrovascular? It proved ultimately this trial proved the efficacy of primary prevention in older populations driven primarily by cardiac event reduction. So now so far before this we were thinking of secondary prevention. Here it is a primary prevention. Primary prevention did not show much result in respect of strokes. For year, again, 27,550 to 27,564 patients with stable coronary vascular disease on statin therapy, followed for 2.2 years. Here, evolocumab, that is Repatha, 140 milligrams or once in 2 weeks, or 420 milligrams once a monthly versus placebo, and added. Baseline is 92, achieved is 30. All stroke reduced by 21%. Ischemic stroke reduced phenomenally by 25%. So proved that lowering LDL cholesterol to ultra low levels with monoclonal antibodies reduces stroke without safety concerns. So it's very important to know that evolocumab or Repatha can be used as secondary prevention tool. And the Odyssey outcome trial is again yet another large trial, 18,924 post-acute coronary syndrome patients followed for a median of almost 3 years. And elorucumab 75 or 150 milligrams once in 2 weeks versus placebo. Baseline is 92 and achieved is 40 versus 93 placebo. Stroke reduction is 28%. So ischemic stroke is reduced by 27%. It confirmed the benefits of achieving ultra low LDL-C on top of the maximally tolerated statins. So this is the article which has appeared on April 9, 2026. Intensive LDL cholesterol targeting in atherosclerotic cardiovascular disease. This has triggered my interest in LDL cholesterol. And here in this article, 3,048 adults, mean age of 64 years, men 79%, women 21%. There's an intensive group where the targeted LDL is less than 55 in about 1,526 patients. And conventional group where the target is less than 70, here it is 1,522 patients. Death, MI, stroke, revascularization, or hospitalization, there's a difference of almost 3.1 percentage points or hazard ratio of 0.67 with a good confidence interval, which is not crossing the line of 1. And you can see that percentage of patients of intensive 6.6 and conventional 9.7. So it's a very significant result. But uh, absolute discretion 3.1 numbers needed to prevent one major cardiovascular event is 32 over 3 years. So if you treat 32 patients, you will help one patient. There are limitations. So some questions are remaining also. Here, blinding was not feasible. The number of primary endpoints was lower than the anticipated. That means people didn't complete the study. In the intense dieting group, 39% of patients did not reach the target at 3 years. The 3-year follow-up period may have been insufficient to fully evaluate the long-term effects of two LDL cholesterol targets. So the target thing is still lingering on, but evidence is favoring lowering. So cholesterol collaboration, this is a meta-analysis of 20 trials involving about 1,70,000 participants. It addressed LDL lowering strategies, resulted in a reduction of 39 milligrams of LDL and a relative risk reduction of about 22% of major adverse cardiovascular events. But there is a selection bias because 9 out of 10 patients who are included in the studies have statins already. But still, the unanswered question is, we know that it's useful for secondary, we thought, but primary prevention, whether the target level of LDL is 70 or less, is it required? Right now, for high risk groups where the coronary arteries are calcified and there is a danger, then this is considered as a primary prevention also. So if you look at the neuropharmacology of atherosclerosis, HMG-CoA reductase inhibitors, the statins, atorvastatin 40 to 80, and rosuvastatin 20 to 40. This is high dose. Initially, we were thinking that people may not tolerate. There are side effects, but you have to monitor them. Reversibly inhibits the HMG-CoA reductase, which reduces the hepatic cholesterol synthesis and upregulates the hepatic LDL receptors. And expected reduction in LDL is more than 50% with the high intensity. The first line therapy for secondary prevention, monitor liver transaminases and assess for myopathy. Then cholesterol absorption inhibitors, ezetimibe, 10 milligrams once a day. It inhibits the Niemann-Pick like inhibitors, transporters in the brushboard of the small intestine, which reduces dietary and biliary cholesterol absorption. Expected LDL cholesterol reduction is 18.5% as monotherapy. And if it is added to statin, it goes up to 25% when added to statin. So what is favored is statin plus ezetimibe. Key outcome data, well-tolerated first-line add-on. Combination with high-intensity statins lowers LDL cholesterol by approximately 65%. So you are now, I think, convinced that we should use statins with ezetimibe. Then the adenosine triphosphate citrate lyase inhibitors, bempedoic acid. The beauty of bempedoic acid is it can be used in patients who are not able to tolerate statins. The reason I'll tell you, it inhibits ACL enzyme upstream of HMG-CoA reductase, prevents hepatic cholesterol synthesis, and upregulates LDL receptors. So the reduction is 18% to 24.5% as monotherapy. In combination, it is 35%. The key outcome, clear outcomes are there. It's a liver-specific activation, avoids muscle-related side effects associated with maybe hyperuricemia and gout, but one should monitor the serum uric acid. But good thing is it doesn't have muscle pains. Now, PSK9 monoclonal antibodies, evolocumab 140 milligrams once in 2 weeks, or 420 milligrams once a month, subcutaneous, and elrocumab 75 or 150, same doses. It PCSK9 mediated degradation of LDL receptors, which I have already alluded to. It increases receptor half-life and clearing of circulating LDL into the liver and metabolize. So the LDL cholesterol reduction is about 50% to 60% as an add-on. There are some studies, 4-year and ODC study, which I have referred to. It's injectable therapy, highly effective for very high risk patients who fail to reach the targets. So I did attempt to do a systematic forest plot formation. You can see the poor stroke outcome. That means it is favoring the intensive or active therapy. None of the studies are reaching the line of no effect, and the hazard ratio is 0.76. That means it is 24% relative risk reduction of a stroke or favor outcome. So you can see these are all the reductions: 16, 22, 21, 25, 25%, and all are having favorable 95% confidence intervals, and they are all large studies. So I think now you're convinced that we should use it. Key outcomes, and when we added this, suppose if you are looking at composite MACE outcome, it is not very effective. So still we are short of the evidence convincingly to us, though p-values are doing great. But here, this is the effect which you can see. And this is a composite effect which is favoring. Pooled illustrative, the no effect line is here. So there is favorable, but stroke as such is not studied. It's a major adverse cardiovascular events, means it can be acute coronary syndrome, ischemic stroke, peripheral vascular disease, and all these things can be prevented. It's a composite outcome, composite MACE, and not much of a stroke outcome in this. So cerebral atherosclerosis, there are some newer agents which are under research, and they're available also. And one is the inclisiran. Inclisiran is a small interfering RNA, siRNA, inclisiran, a GalNAc conjugated simple RNA. Inclisiran silences hepatic PCSK9 via twice yearly subcutaneous dosing after initial loading. It sustained 49.4% LDL cholesterol reduction up to 6.8 years. It was demonstrated in Orion 8, where about 3,274 patients were studied, and 78% are they reached the target LDL level. The pooled Orion 9, 10, and 11 studies showed 32% fewer MI, stroke, and MI. You can see the 95% confidence interval is crossing 1. MACE reduction remained non-significant, likely reflecting underpowered short duration trials. So they have designed Orion 4 trial, which is in phase 3, and also Victorian 2. They are evaluating long-term stroke prevention, so we have to await their studies. But inclisiran is used. Inclisiran is used nowadays. It's very costly drug, about 1,13,000 per 6 months course. Small interfering RNA, inclisiran, clinical evidence and mechanism is depicted in this. And usually the mechanism and administration is, this is a twice yearly subcutaneous injection, and in the PCSK9 mRNA and increased LDL deficiency. So it silences LDL receptors. Okay. So there is a sustained LDL cholesterol reduction about 49%. And what it does is stroke and MACE reductions happen. MI is very significant. Relative risk reduction is 0.68. But non-significant findings are stroke, you add 0.92. So overall MACE reductions are favorable. But if you look at the stroke alone, the answer has to come. It's not had to come. It will come in very soon, but right now it's not there. But major cardiovascular, especially coronary artery disease, can be prevented. So people who got coronary arteries which are calcified, which have got more than 70% stenosis, are good candidates. So there is one more thing that is you can see inhibition of ANGPTL3, that is evanacumab. It's a loss of function variant of this particular enzyme, which is an inhibitor of lipoprotein and endothelial lipases associated with lower LDC, triglycerides, and coronary risk. So by targeting this evanacumab reduces lipids independently of the LDL receptors. This is also another drug which is helping in reduction of LDL, but it's not through LDL receptor mechanism. It is a 49% LDL reduction was observed in the phase 3 ELLIPSE trial, and when 15 milligrams per kg IV was given and once in 4 weeks, sustained over 24 weeks. So this also is a drug which is favored for reduction of LDL cholesterol. Still, we have to study it more before we use it. So this mechanism, LDL cholesterol reduction is 53.2%, and 30% people have achieved the goal, and triglycerides are reduced. So these LDL or triglycerides, apolipoprotein, these are all called surrogate markers. They have to really they have to really see whether really stroke is prevented or not. My mere reduction of LDL cholesterol is not the end of the study. By reducing LDL, we should be able to prevent stroke. That's the most important target. So that clinical outcome is to be studied. So next generation oral therapies, obicetrapib, an oral selective CETP inhibitor. Obicetrapib lowers LDL cholesterol by blocking cholesterol ester transfer from HDL to ApoB containing lipoproteins and upregulating the hepatic LDL receptor pathway. This study called Broadway study, and it's also 9,500 acute so cardiovascular and stroke patients showed a 33% LDL cholesterol reduction at day 84 with obicetrapib 10 milligrams daily, and it reduced 21% in major adverse cardiovascular events at 1 year. And LDL cholesterol fell by 36% by week 12 and 41% by week 52 in this Brooklyn study. And so this again a favorable outcome study about the reduction in the cholesterol. So the Broadway sub-analysis indicated potential cerebral lipid effects of obesity. So one should know that hydroxycholesterol. So go back. Decreased 11 to 12%, while the A beta and tau ratio is that is A beta 42/40 ratio rose 8%, particularly among ApoE4 carriers. So one thing important is the cholesterol metabolism is in the brain is localized. Whatever happens in the outside, it's only preventing the cardiovascular and indirectly preventing the stroke. Now, the cholesterol metabolism you all can refer in brain is entirely different from what happens outside the brain. So Broadway trial, approximately 9,500 patients, 33% reduction in LDL cholesterol, 21% reduction in major adverse cardiovascular events, not stroke. So the obicetrapib, which is a mechanism of action, 10 milligrams once daily, and transfer of cholesterol esters from HDL cholesterol, that is good cholesterol, to apolipoprotein B containing lipoproteins, that's a bad cholesterol, and this is blocked. So HDL level will increase. So that's a very interesting thing, and you can have a reduction in the LDL cholesterol level. So lastly, we see that in vivo gene editing also has come. So gene editing WER102, WER101 used a CRISPR-based editor in an LNP to silence hepatic PCSK9, achieving up to 73% LDL cholesterol reduction over 270 days. It's phase 1b trial, and development paused after transient grade 3 hepatotoxicity. So where 102 delivered PCSK9 reductions up to 88% and LDL cholesterol reductions up to 62% from a single IV dose, with effects lasting up to 18 months. So there is a promise that these things will also help in our armamentarium of cholesterol fight. So where 101 is this, where 102, which is more favorable, and there is a LDL cholesterol reduction of up to 62%. It's a single injection, and single intravenous infusion will act on the hepatic receptors. So conclusions and take-home messages for this talk. Early combination therapy outperforms statin monotherapy for secondary stroke and TIA prevention. So lesson is, in addition to statin, we should add ezetimibe or bempedoic acid. If patients are not able to tolerate high-dose statin, you club bempedoic acid with ezetimibe. In atherosclerotic non-embolic ischemic stroke or TIA, start high-dose intensivity statins promptly. Ezetimibe 10 milligrams when atherosclerosis is confirmed for 65% LDL cholesterol reduction can be added. So how much more LDL cholesterol is reduced when you add ezetimibe is a new finding after this talk, and we should use. So target LDL cholesterol by risk. If high risk patients, it is less than 70 milligrams per DL. More than less than 55 milligram DL plus more than 50% baseline reduction is very high risk. These are two categories: high risk and very high risk. If it is still not possible, then escalate to PCSK9 inhibitor. If statin ezetimibe therapy is insufficient, bempedoic acid is an alternative for statin intolerant patients. So that also is failed. Then you add PCSK9 inhibitors. Together, these strategies maximize lipid control and lower recurrent vascular. So a diagnostic flow chart can be attempted at the end. Acute ischemic stroke, TIA diagnostic workup. Atherosclerotic etiologies are there, that is carotid stenosis, ICAD, unplug burden, etc. The strict treatment to target high intensity statin. Goal is LDL cholesterol less than 55 or more than 50% reduction, and rapidly step up to ezetimibe, PCSK9, or ezetimibe or bempedoic acid. So non-atherosclerotic etiologies like cardioembolism, dissection, others, individualized treatment, standard secondary prevention consistent with etiology, not these drugs. So that's the message of this talk. I think that's all from my side. Thank you very much. And if there are any questions anybody wants to ask, or you can read later. The topic is very important for day-to-day management of our stroke cases for secondary prevention. The lesson is, we should add ezetimibe or bempedoic acid to keep the LDL cholesterol level less than 55 in very high risk patients, and less than 70 at least in high risk patients. Any questions? You're all muted. You can unmute and can raise your hand.
Hello, sir.
Yes, good evening.
Good evening. I'm Dr. Pramod Umarji. I wanted to know the position in diabetics and obese people. Means
Okay.
whether weight reduction will reduce cholesterol that much, etc.
No, actually, weight reduction, semaglutide or Monjaro, we have to use GLP, GLP-1 inhibitors, and so that's important. We have to use to reduce the weight, and it may not decrease the cholesterol. Indirectly, it may have, but directly, you'll have to use these drugs. What I do.
Right. Thank you.
Please tell the summary again once. So this summary can be. Conclusion is that early combination therapy with atorvastatin, either ezetimibe or bempedoic acid, that is for secondary stroke or TI prevention. That means already patients have suffered, they got risk factors, they had stroke and minor TIA or high risk TIA. Then you have to use this combination. In non-embolic, that means no cardioembolic stroke, ischemic or TIA, start high-intensity statins, atorvastatin 80 milligrams or rosuvastatin 20. People may tolerate better rosuvastatin, add ezetimibe or bempedoic acid. when atherosclerosis is confirmed, because your target here is 65% reduction in LDL cholesterol. That's most important. And second, target LDL cholesterol by risk. High risk, it is about less than 70. Very high risk, it is less than 55, or whatever base level is there, it should reduce by more than 50%. If this method is not successful, you have to add PCSK9 inhibitor. If statin ezetimibe, a statin bempedoic acid, or bempedoic acid ezetimibe combination is insufficient, together, these strategies maximize lipid control and lower recurrent vascular risks. And that is the summary of this. And you can see atherosclerotic etiologies, carotid stenosis, ICAT, and plaque burden as assessed by MRI. Then high intensity statins, LDL cholesterol less than 55 or more than 50% reduction, step up ezetimibe, bempedoic acid, PCSK9 inhibitors. That's all I can say in summary. Okay, I told the summary again. What else you want? All right. Okay, if no more questions. All right. So good night, everybody.
Good night, sir. Thank you, sir.
Thank you.
Good night, sir. Thank you, sir.
Welcome.